Right. Hello, everyone. Welcome to A Tale of Two Chapters, brought to you by the New York and Argentina ACC chapters. As a reminder, we will get started shortly, but as a reminder to all attendees, please keep your camera and your microphone off during the event. And if you have any questions during the event, please put them in the chat box and we will get to them at the end of the case. Then I am excited to introduce Dr. Panza, who will be the moderator for the event today.
Thank you, Taylor. So welcome everyone to the third webinar between the chapters of the American College of Cardiology in Argentina and New York. For those of you who may be joining for the first time, this is one, but certainly not the only activity that is part of this pairing, this twining between the two chapters that were joined really several years ago from the American College of Cardiology Central House. The format that we have followed will be identical to the ones that we followed in the two previous iterations. We will have a case presented by one trainee from one of the chapters with comments from faculty from the other chapter, and I will introduce the faculty in a moment. The purpose of this seminar is not so much to present those zebra cases or cases that are so out there, but rather to have a interaction between the two chapters to learn what we would do here in the United States for cases that are presented from Argentina and vice versa. So comments from the audience are important, and you can post any questions or comments that you may have on the chat line. I think that this agenda has been distributed. My role would be really like a time policeman. So I will make sure that we finish no later than the time that we have slated to adjourn, which is 5:20. So I will make sure that each presenter strictly adheres to the time. Okay. So we will start with a case from Argentina that will be presented by Dr. Mocorrea, who is from the Hospital Austral outside of the city of Buenos Aires. And then the case will be discussed by Dr. Stephen Pan from Westchester Medical Center and by Dr. Maria Caras from Weill Cornell Medical College in New York. Then we will have the pleasure of hearing from two of the trainees from Argentina that have rotated through hospitals here in New York State. And those will be Dr. Ana Laura Micelli and Dr. Cristela Massin. And then we will move on to the case from New York that will be presented by Nismat Javed from Mount Sinai Morningside, where she's a fellow. And that case will be commented on by Dr. Mariano Falconi from the Hospital Italiano in Buenos Aires and by Dr. Andrea Astesiano from Tunuchan in Mendoza, Argentina. I will be moving the slides, so for the presenters, just please say we're going to do it the old way. Just say next slide, and then we'll move moving. The idea is that I have put all the presentations into one to avoid the problem of switching the people who share the slides. So it will be my presentation, and I will be moving the slides. And like I said, my role will be to coordinate the questions and making sure that everybody is on time. So without any further ado, we're going to go to, I'm sorry, I think I have the, let me see, I'm sorry. We're going to go first with the New York case. I apologize about that. I had the wrong agenda. So Dr. Javed, if you can start.
Sure. Thank you so much for this opportunity. As Dr. Panza mentioned, first year fellow at Mount Sinai Morningside, really excited to share this interesting case that we had and to talk about basically the case of anomalous coronaries in a patient who had presented to us with acute coronary syndrome. And we can have the presentation on the next slide. Yeah. So this is basically a 72 years old female who presented to our emergency room with typical symptoms of left-sided chest pain that had been persistent for the past 1 day or so, almost pressure-like in sensation. And her pertinent past medical history included hypertension and history of active smoking, almost 30.5 FACC years. When she was coming to us before that in EMS route, she was given almost 324 milligrams of aspirin and one sublingual nitro. Other than that, she was a pretty well-to-do patient, except for the fact that this was the second time she was having this chest pain episode. Upon arrival to the ED, she was otherwise hemodynamically stable, a little tachycardic, but saturations were noted to be 98% on room air, and blood pressure was otherwise very stable. And the examination findings are on the next slide. So she was euvolemic on exam actually, and just was a little bit anxious. In fact, when she had received the sublingual nitro, her chest pain had resolved and somewhat had improvement. However, when we had the lab workup and subsequent findings that were a bit concerning, predominantly for an LDL level of 105, and then the fact that her troponins had continued to rise. So it went from almost a figure of 570 to 618 to 744. And then the rest of the labs, however, seemed normal with potassium of 4.6, magnesium was fine, and creatinine was 1.1. So this concerning these findings, when we'll look at the EKG, she also had some T-wave changes, and that's on the next slide. So her EKG showed this normal sinus rhythm, wasn't at all tachycardic, but as we can see, there are some T-wave changes well appreciated in leads 2, 3, and some Wonderlight morphology that's also very well visible in V1 to V3. These changes were actually new compared to her prior EKGs, and that's what also prompted us to think that this is possibly NSTEMI, and therefore we admitted her to the CCU, started her on heparin and antiplatelets, and then planned for her diagnostic CAT, of which the findings we have on the next page. So as we can see from panels like A to C, initially in the AP view, it's clear that she had this mid RCA lesion. However, she also had an interesting circ course that was a bit puzzling for us. She had this prox left circumflex lesion as well as a distal circumflex lesion. However, angiographically, it was a little difficult to kind of understand. We were able to identify that this is indeed coming from the RCA, but the exact territory of the circ was one of the major questions that we had during the diagnostic CAT, and it becomes more and more clear on her like left anterior oblique views, as we can see. So at this point, I would like to open this discussion in the sense that the strategy of all our panelists here in terms of what would be the steps going forward.
Thank you. That was rather succinct, which is great. So I don't know whether Dr. Falconi is, I don't see his name. Dr.
Hello.
Falconi?
I'm here, just in case.
Okay. Well, why don't we start with you, Dr. Astesiano, and then if Dr. Falconi joins, then
Okay.
he will be
I
commenting.
think, thank you. This is an interesting case. I think the origin of the circumference is from the right coronary artery, and it's a rare variant with a low prevalence, I think. In elderly women, this abnormality could potentially have been detected early, I think, with maybe an echo, I think. Given her clinical background and her echocardiogram with dedicated assessment of the coronary ostia, I think. Coronary CT would be an option. I think it's superior in this case, not in the acute, but late foresee the anatomy and the relationship with other structures. I don't know, to detect the high risk signs for major events. I don't know if I should go on.
Dr. Falconi, do you want to make any additional comments? I think you're muted.
Muted.
Yeah. Dr. Falconi, I don't know whether you're speaking, but I cannot hear you. Taylor, you think that he's muted? I don't see the muted sign.
No.
I don't see that he's muted. I wonder if there's a microphone mishap. I'm not.
Okay, maybe if you are agree, maybe we could speak about the high risk features.
Okay, yeah. Well, we'll let you go on. So, Dr.
Okay.
Falconi,
No.
let me see.
No?
He's back.
Okay.
Yes,
Yeah, now
No.
you're back. Now we can hear you. Yeah.
No? Hello?
Yeah,
yes,
perfect.
Yes?
Perfect.
Listening? It's
Yes.
okay?
Yes, it
No,
is.
yo no los
Go
escucho
ahead.
ahora. Okay. The audio is okay.
Yes, it is.
Wait a minute, please. And okay, sorry for that. We have a technical problem here. I think it's solved. I think it. Just let me know if you're listening okay. I agree with all the discussion that Dr. Astesiano has informed me a few minutes ago. I think this is a very frequent or relatively frequent coronary anomaly, but it is a hazardous situation for resolving it in the cath lab because of the technical concerns about going inside the left circumferential artery that it's originating in a very anomalous situation. So the patient has a severe lesion of the right coronary arteries, but also has lesions in the circumflex. I don't know really which is the culprit lesion. I don't know if you could identify because the AKG is not clear for the culprit lesion. So if the culprit lesion is the right coronary artery, well, it is relatively easy to solve. If it's the left circumflex, I think it's really hard to get in the circumflex artery that it's going in that way. So CT scan is a good technique just to have a clearer imaging of the anatomy, but I don't know if the patient is sufficiently stable to stop here, go to the CT scan, perform a CT scan, and they go again to the cath lab because this has to be resolved either in the operating room or in the cath lab. If the patient is unstable, I would go for the right coronary artery, which is easy to solve, and if that's not solve the problem, go to the circumferential artery. If we have time, maybe a CT scan would be useful just to understand which is the anatomy in relation with the other structures. But I agree that the main question here is the patient is not having an elevation of the ST or depression of the ST. If the patient is stable, asymptomatic, I would try to make a CT scan just to understand better the anatomy.
So I have a question. Both discussants mentioned the CTA, and I believe that the heart rate was 110. So to what extent is that heart rate a limitation? And we haven't heard that the patient was hemodynamically unstable, so that maybe the patient can receive beta blockers. But can you tell me what is the maximum heart rate that one can tolerate to get good quality of images?
Very good question. It's a very bad heart rate for diagnosing lesions in the coronary arteries, but I don't need that because I have the angiography. What I need to know is what is the anatomy of the main artery. So I think I don't want to see the lesion. The lesion is for the angiography. I have the angiography. So the heart rate is high, but to look for the way the right coronary artery gets the AV surge and to understand where is the circumflex, if it's retroaortic, interarterial, where is the LAD, that's enough with 110 beats per minute. It's just to see where is the origin and where is going each of the three main arteries, not to see inside the arteries and to see which is the severity of the lesion. I don't need that information. I just have that.
Thank you. Dr. Astesiano, do you want to make any other comments?
yes, maybe. I don't know. In addition, CT would allow detailed analysis of plaque characteristic. Just my only doubt is the left anterior because it seems like with thrombus. And I don't know if it is clear, at least in the images. So it would be interesting.
So let me ask another question along those lines. So I hear, first of all, I'm not a CT expert, but I hear from the CT experts that photon counting is a very upcoming and important technique that may allow better plaque characterization, even in the presence of calcium. So Dr. Falconi, I think, raised the point of which one is the culprit artery, because you have two lesions that each one, particularly because of the non-helpful EKG, either one could be the culprit. So do you think that now or maybe in the future we may be able to answer that question as to which is the plaque that is ruptured when we have two in question, like in this case?
Okay, it's very interesting what you said. I think that in the near future, not now. I'm not sure that we can now say, okay, do a photon counting CT scan just to see which is the culprit artery. I think that the problem with this patient that we don't have ECG, we don't have changes, is the changes. And if we have changes, it also will be difficult because both arteries go to the inferior territory and the lateral territory. So we will not be very sure if it's the right coronary artery or the circumflex artery. But answering your question, I think photon counting is very interesting technique. It has to have more time to really prove it has the strong evidence that we think it has, but it's doing the right way. But I think a couple of years yet to answer your question, maybe 3 or 4 years more.
Thank you, Dr.
But in this case, I think there are two problems. One is the culprit lesion, and the second is very difficult for the person who is going to perform the procedure to enter the circumflex artery. If he's in the cath lab and says, it's easy for me, okay, go on, just go on. The problem is that if the left circumflex is very hard to catheterize, then we will have to discuss which is the other option, surgery. And if we go to surgery, I would like to know better the anatomy. But if the cath lab says, I can do it easy, I don't care about the circumflex, I can get inside it very easy. Also, it's an anomalous artery, I can get inside. Okay, let's go on and solve the problem right now.
Excuse me,
Dr. Astesiano?
may I comment?
Yeah, sure. Please, go ahead.
I would like to say that the right coronary artery is really easier to treat. And for the left circumflex, I would choose for left amplatz AL1 or 2. And the culprit lesion is the one which is distal at the left circumflex. And to see, probably we can treat also the proximal, but the complex lesion is the distal one. And so both lesions could be treated at the same procedure, in my opinion. And
Thank you.
That's all. Thanks. Nice case.
Thank you for those comments. Dr. Astesiano, do you want to add anything?
I only have a question. What is the orange narrow in the diagonal branch?
I'm sorry, can you repeat the question? What is the origin?
I don't know what is the orange, or I don't know, yellow narrow.
Oh,
no, yellow, the orange. I think the color is orange.
You mean on panel C? Is that
yes.
Okay, Dr. Javed, can you clarify what does the orange arrow, there's a yellow and an orange arrow on panel C. Can you clarify what the orange arrow is?
So basically that was just to emphasize that, all the points that the discussants have raised, completely valid points, and those are the exact same questions that we also had. The orange arrow is just to emphasize the the continuity of the course of the arteries. That's pretty much it. It doesn't signify a lesion specifically. The lesions severity and I would say the number of lesions are more emphasized in panel C. So that's just to say that this is like the course of the artery.
Okay, so Dr. Javed, let me ask you a question. Don't don't give it out yet, but just one question. So when the patient was on the cath table, was the patient
Yes.
asymptomatic at that point?
At this point, she was chest pain free. She was alert and oriented ×4. She was not tachycardic. Heart rate, I believe, was around 98. And then there was nothing on the monitor from like ST elevations, any changes whatsoever. She was completely fine.
Okay, so let's stop there. So let me, because again, as I said at the beginning, the purpose of this is to see what would you do in this situation. So let me ask both Dr. Falconi and Dr. Astesiano. So the patient is on the cath table. We saw the EKG. We see the cath. We don't have, this is not a movie or a video, but since like the TIMI is TIMI 3. So would you take the patient off the table to do the CT angiogram, or would you act differently? Dr. Falconi?
Okay. I imagine in this situation, I would be in the other side of the glass with this closes, and it is inside the cath lab would be the hemodynamist, the cath doctor. So I would say, how's the patient? Patient stable. Okay. Is with chest pain? No. Okay. Can you abort the right coronary artery now? Yes. Okay. So let's solve the right coronary artery. I think it's a very severe lesion, and it's relatively easy to treat. Okay, that's okay. And then what you can do is try to catheterize the left circumflex. I'm worried about the B imaging, the B, not the A, because in the A imaging, it looks like the left circumflex is originating in a very easy angle, but in the B, you see that it's very hard to get inside the left circumflex, and it's an angle that is more or less 70 degrees to the right, to the left. You see, you go to the right, you get inside the right coronary artery, and then you have to go to the other side. She's signaling that. That's what I say. I think that's difficult. So, one situation. Let's solve now the right coronary artery, and let's see if we can do something to the left circumflex. If we can, let's do everything. If we cannot, let's stop here and let's go out. And maybe it's not a very large myocardium territory, which is irrigated by that artery. I see that there are two severe lesions in the left circumflex, but it's very, very small branches. So maybe we can be conservative, treat the right coronary artery, and wait and see. Okay. That's one possibility if it's very hard to catheterize the left circumflex.
Okay, so Dr. Astesiano, would you recommend that the patient be taken off the table for the CTA, or would you agree with Dr. Falconi to treat the right coronary? That seems to be easy, and then see what happens.
No, I completely agree with Mariano. So I think the discussion was helpful, but I will leave the CT scan for later. And also, given the elevated rate and the age of the patient, probably has a lot of calcium. So that's the thing.
Okay, thank you. Well, this is a great discussion, and we're still on time. So let me turn it back to you, Dr. Javed, and tell us what you guys did.
So interesting points. At this point, I think we halted, the patient was still on the table. Then we reviewed panels A and B specifically with the patient. So we discussed the exact options, actually. We spoke about the RCA, and we mentioned that we could either stent the RCA lesion and then take care of the circ, or have a closer look at the circ and then treat that first, followed by the RCA. And then additionally, given the way the lesions were seen in the circ and additionally the course of the circ, we also mentioned the high risk of complications, as well as the fact that there could be perforation rate and the rates could be higher, and the fact that it was a very complicated anatomy. So we also at that point discussed the option of dedicated imaging with the patient, which, as Dr. mentioned earlier, about the CCTA. So the patient herself had opted for the CCTA. During this time, there was also a discussion with the surgeons with regards to if surgery would be a better option for her. However, patient was very apprehensive of like any surgical interventions. So after having all this discussion with the patient, we first actually took her for the CCTA, which helped us visualize the anatomy a little bit better and understand the course of the circ better. After which we subsequently resumed the case. So we have the CCTA results actually on the next slide. So as we can see here, it's a very unusual course of the RC. And then this is one of the circ lesions that's been seen here, pointed by the arrows. After we had gotten this results, that's when we decided to take care of both the lesions in one single settings. And this time we were a bit more oriented in terms of the technical problems that we would experience with the circ predominantly. And as mentioned in the next page, we have the RCA. So we first took care of the RCA initially. That was, as mentioned earlier by many of our esteemed discussants, it was easier to take care of. We stented with a 3.5 by 38 mm stent. It was well opposed and well placed. After that, we went after the circ. So as expected, it wasn't the angle initially that was the problem. It was rather the lesion, like the prox lesion morphology itself. So initially we did PTCA, had to dilate the lesion with a compliant balloon and subsequently stent that first, after which we were able to reach the distal lesion in the circ and then subsequently take care of it. So these were the final results with the TIMI 3 flow. Patient, although had no chest pain in the middle of the case that we mentioned, but she reported doing well after. We've been seeing her in clinic and she's very well adherent with her medications. LDL has dropped down to 50, I believe, and she's in a smoking cessation program, and she hasn't had any chest pain episodes after that.
Okay, so let me ask you, so do you think in retrospect that you know what the culprit lesion was?
So that's one question that even before presenting, I had asked my my mentor as well and the interventionalist who did the case. So it was very vague exactly what the culprit lesion was, because both of the lesions, morphology wise, they were 90 to 95% stenosis. So that confusion had still remained. It was more in terms of which lesion to go after first and whether if, for example, we would have still gone with, say, for example, treating the RCA and then leave the other lesion for later, or take care of both of them in the same setting. So that was more of a decision that the CCTA definitely helped us do. Because if it hadn't shown such severe stenosis to begin with, or such a complex lesion, or the fact that it was even calcified, then probably like strategy would have been different.
And we didn't mention the left main.
So with regards to the left main and LAD, so that did not have like any thrombosis or stenosis. Specifically, again, then the pictures are not on the presentation, but in the angiofilms, they were relatively clear.
Okay. I think that Dr. Navarro Estrada showed up with a raised hand. Jose,
Yes,
do you have a comment?
I would like to, sorry.
We can hear you. Not anymore. Okay, well, Dr. Falconi, do you have any quick last comments? And then Dr. Javed wants to make some points.
No, just congratulations. It's a very nice case, very well presented, and very interesting, the situation which we present. I think that the main condition here is that the patient was relatively stable and with no ST changes. If that's not the situation, other would be the discussion. But it's very interesting, and it's not an uncommon coronary anomaly. It's the most common coronary anomaly. The problem is when the patient has coronary artery disease. But it's very common to see the left circumflex in the retroaortic position. It's the most prevalent coronary anomaly we found in CT.
Dr. Astesiano, just a 1-minute comment, if you have one.
No, I think I'm done. I wanted to see more imaging from the CT, but.
Okay. Well, Dr. Javed, would you like to complete with this slide?
Yes, I will be mindful of that for next time. Thank you so much for all your comments. So There is a lot of discussion about CCTA potentially taking role in an interventional world. There is so much of data with respect to prognostication. However, this was an interesting setting in which we basically saw the anatomy of the lesion particularly better. And it helped us a lot in the sense that there was this idea of the kind of difficulties to be anticipated, and additionally, the level to which we could actually use our equipment in order to navigate those barriers. Now, currently, I mean, the practices, and even right now, the discussion going on in the world is with regards to early prevention when it comes to coronary CTs and in low risk populations. But it's a tools that could potentially be also used alongside maybe OCT and IVUS in terms of in the future, and would be interesting to see in terms of where does this technology take us.
Thank you. Dr. Navarro-Estrada, if you're still there, we do have a couple minutes or anybody else has any comments. So I think that this is interesting because obviously we always think of CT and CTA as part of prevention, just like you said, but now we're trying to expand the role of CCTA in a situation, albeit unusual, for an acute coronary syndrome. And I think it's, it's interesting to see that you guys actually decided to take the patient off the table to do this. And I second the comment from Dr. Falconi about, the patient had, that's why I asked you, the patient had been with chest pain or the STs were more dynamic, then I think that probably you would have done something different. But I think that in a way this speaks to the always expanding role of CCTA to this unusual circumstance. And I'm sure that you had a lot of discussion and a lot of brains put together before doing what you did.
And the other, just 1 minute, Julio, is it's very important what you said about heart rate, but it's all about what we want to see. If we want to see the lesion, you need the bradycardia, of course. But if we want to see the pulmonary vein for an ablation, we usually do a CT scan with atrial fibrillation and 120, and we see the pulmonary veins very well. And if we want to see where goes the coronary arteries, it doesn't matter very much how much is the heart rate. We need the cath lab for the lesion and the CT scan for the anatomy, and that's fantastic.
Recently, and I'm looking at the clock, so we do have a couple of minutes. Recently, I was part of a discussion of a patient that had all the characteristics of a Takotsubo. Okay, and I still think that you cannot make diagnosis of Takotsubo without seeing the coronary arteries. And I asked, well, what about doing a CCTA? Obviously, if you are going to intervene, you're going to need a cath, and there was an issue of the heart rate, which is why I asked that question. So, can you, in a situation where you want to know about Takotsubo versus occlusion of the LAD, and that's all you want to know, can you do a CCTA even if the heart rate is high? And it seems that from the experts here, it seems that the answer is yes, you can do it. And then if the LAD is occluded, then you can move the patient to the cath lab for an intervention. Well, thank you. This very, very interesting, and I think it served the purpose of what we want to achieve. So I do want to move to the next part of the agenda, and another very important part of the twining of the two chapters is to have trainees from Argentina to rotate through hospitals in New York State. And this is a program that is now, I think it's now we're on our third or fourth academic year, and it has been extremely, extremely useful and productive. So we do have time to listen to the experience that these trainees have had in the last academic year. So we're going to start with Dr. Ana Laura Miselli. So Ana, if you can briefly introduce yourself and tell us briefly about your experience.
Thank you, Doctor. Good afternoon, everybody. My name is Ana Micheli, and I'm a fourth-year cardiology resident from Argentina. I'm currently doing my training at the Italian Hospital of Buenos Aires, and I spent this past October at the heart failure department at Montefiore Medical Center in New York City as part of a grant that was awarded to me by the Argentine chapter of the American College of Cardiology. So this experience for me was truly enriching, both on the personal and a professional level. I have the privilege of doing my training at the Italian hospital, as I mentioned before, which is a leading center in heart transplant in my country. But Montefiore happens to have one of the best heart transplant programs in the US. So when I did my observership, I could be in contact with a high volume of patients, and not only heart transplant patients, but patients with left ventricular assist devices. And since, unfortunately, we do not have LVADs available in Argentina yet, the management of these patients was completely new to me, and that aspect of the rotation was particularly interesting and stimulating. Another aspect that I enjoyed a lot was being able to observe the heart failure team meetings that were held twice a week. As I mentioned before, Montefiore has a high volume of patients, so these meetings involved a great number of professionals. The meetings involved cardiologists, nurses, surgeons, social workers. So it was a truly multidisciplinary team, and they discussed how the hospitalized heart failure patients were doing, and they presented patients that were in pre-transplant evaluation and decided whether they were going to heart transplant or LVAD. So that was quite interesting to observe too. I also took part of the cardiology lectures addressed to the cardiology fellows that involved a wide variety of topics, not only within heart failure, but within general cardiology. And most of these lessons were in charge of experts in the field. So they were these top level classes that I really enjoy. And I even got to be part of a lecture about hypertrophic cardiomyopathy in charge of Dr. Brownwald himself. So that was really exceptional. On a more personal level, this rotation kind of put me outside of my comfort zone, because if I'm completely honest, I've been speaking English since I was very young. But at first, I found that following the English, like technical medical language, was a bit challenging, especially because of the abbreviations and the acronyms that we use. So at first it was challenging, but I think that in the end of the month, I can say that I became a lot more fluid and a lot more confident with my English. And of course, getting to be an entire month in New York by myself was amazing. I got to visit a lot of museums, enjoy the food, sightsee. So that made the experience even more meaningful. I'm really grateful for the Argentine Society of Cardiology and the Argentine chapter of the ACC for giving me this opportunity. I think that everything that I experienced this month that I was in the US, both inside and outside of the hospital, contributed to a significant personal growth, I would say. And I really hope that I can be part of a similar experience again in the future. So thank you very much.
Thank you. That was really very, very nice. And I think it's great to hear this experience. Dr. Massin, your turn.
Good afternoon to everyone. My name is Cristela Massin. I am a four-year cardiology resident in Corrientes. It's a small city in the northeast of Argentina. I work in Instituto de Cardiología de Corrientes, and during the month of April and May this year, I had the chance to do an observership at Westchester Medical Center in Valhalla. During this time, I joined the Coronary Care Unit, the CCU, and Heart Failure and Cardiac Transplantation Services. I think it was an extremely enriching experience because I was able to observe a great amount of procedures such as right heart catheterizations, coronary angiographies, endomyocardial biopsies, and I must say that from the very first day, the entire medical team made me feel like I was part of the group. They actively include me during morning rounds, and they value my input. I really felt like I was part of this entire group. And I think that every situation was approached as a learning opportunity, which I think is great. And I must thank these cardiology fellows, especially Dr. Amro Algan, Dr. Shirak Shah, and Nathaniel, for their generosity and to be approachable for me and to really transform my experience there, as well as some internal medicine residents, especially Stephen Buffer, Christopher Politis, and Rimsha Anna. They were great to me, sorry. And I think that the team training in Westchester Medical Center is outstanding, and the work environment is extremely comfortable. When I was thinking what to say here, I thought, who should I thank first? And I think that will be my tutor during these 2 months, Dr. Julio Panza, who I think is a brilliant, curious, and highly capable physician, and he's always willing to teach everyone and to contribute with like a remarkable sense of clarity during cardiology department discussions. I really value that. And he has a human approach and an educational attitude that really impact this experience for me. And also, I had the pleasure to meet Dr. Panza's family. They made me feel welcome immediately and less far from home. And I thank Joy for that. Thank you, Dr. Panza, and thank you, thank you, Joy. And also, I had the opportunity to meet Dr. Stephen Pan in person, who was participating in this meeting. And I remember clearly that the first time I heard him speak, I was thinking, how is it possible that so much knowledge can be contained in just one single mind? And he's exceptionally intelligent, meticulous, and he's always willing to teach. I remember morning rounds discussing 2 or 3 cases with him, and I remember learning a lot from that. And for all this, I sincerely thank you, Dr. Pan. And last but not least, I should thank Dr. Alan Gass, who allowed me to accompany him in the outpatient clinic. And I think this was an incredibly formative experience. Dr. Alan Gass is an extraordinary person. He's empathetic, enthusiastic, and he's humble. And I admire the bond that he made with patients. And I think that I learned a great deal by his side, both clinically and personally as well. And just to conclude, and to make a long story short, I recommend the experience 100%. And I have nothing but words of gratitude to all these people that were involved in making this transformative opportunity possible. Thank you.
Thank you so much. Those are great testimonials, and I'm sure that Katarina and Taylor are listening very attentively to this and transmitting that to the governors of the chapter that really have made this possible through the granting of a stipend for the trainees. All right, so we are on time, so we're going to move on to the presentation of the case from Argentina. So that will be by Dr. Mocorrea. So Dr. Mocorrea, can you please introduce yourself and go ahead and tell me when to move the slides?
Thank you very much, Dr. Panza. Hello, my name is Bautista Mocorrea. I'm a third-year cardiology resident from Austral University Hospital in Argentina, and I'm here to present the following case on behalf of the Argentina chapter of the American College of Cardiology. If you could pass, please. So our case starts with a 50-year-old male patient with no prior medical history, referred no medication, substance abuse, prior hospitalizations or surgeries, who was developing a progressive exertional dyspnea developing during the past 3 months without any visits to a clinic, and who had a clinical debut with 2 hospitalizations in the past 2 weeks for acute heart failure. The patient was from a more rural area of our country, and after his second hospitalization, he was referred to our hospital as a high complexity center for refractory heart failure. Patient's medication is listed below. He was on furosemide, spironolactone, bisoprolol, and dapagliflozin, which had all been started recently in the context of the prior hospitalization. You could pass. On physical examination, our patient had a heart rate of 70, a blood pressure of 100/70. On auscultation, he had a systolic murmur in the mitral area and some lower extremity edema. And on respiratory evaluation, he had a respiratory rate of 16 with adequate hemoglobin saturation at 97% and bibasal Rayleigh. Patient's EKG on admission shows normal sinus rhythm with findings of low voltage in limb leads and a poor R-wave progression in precordial leads associated with a slightly widened QRS complex at 120 milliseconds with no bundle branch morphology. On chest X-ray, we can see an enlarged cardiac silhouette with signs of biventricular enlargement, along with signs of congestive heart failure with a redistribution of vasculature to upper lung fields and congestive lung hilum. And following this, the patient's blood work on admission showed an alteration with an elevation of creatinine, bilirubin, and transaminases associated with an elevated pro-BNP values. In this context, the renal and hepatic deterioration were interpreted to be secondary to a congestive state, along with a hyponatremia of 132, which is not marked in red. But all these alterations were interpreted to be secondary to a congestive state and not primary pathology. Good. Pass, please. On echocardiography, you can see in the top images parasternal long axis, in which we can see a severe dilation of left ventricle, left atria, and right ventricle with preserved wall thickness and severe systolic dysfunction. Along with this, we can see mitral leaflet tethering, leading to a secondary mitral regurgitation with annular disjunction with essential coaptation defects, which, as we can see in the images on the right, on Doppler imaging, we can see leads to a severe mitral regurgitation. At the bottom left, in a 4 chambers view, we can see that there is a severe dilation of all 4 heart chambers. And regarding the left ventricle, we can see that there is a global hypokinesia with no regional wall movement abnormalities or thickening abnormalities associated with a severe systolic dysfunction with an estimated ejection fraction of 24%. You can also see dilation of right ventricle with an estimated pulmonary artery systolic pressure of 40 millimeters of mercury and dilated right atrium, and not seen in images, but a dilated inferior vena cava with a diameter of 40 millimeters. Moving on. Coronary angiography was performed, in which we can see no significant lesions in any of the main epicardial coronary arteries. In this context, regarding our patient, in which we have no primary valve disease and a dilated ventricle with a reduced ejection fraction and normal coronary arteries, at this point, we can diagnose a dilated cardiomyopathy. And as such, the follow-up was realized with the next image, please. We performed a cardiac MRI in which we can see similar findings to the echocardiogram with severe dilation of all four heart chambers, with a global systolic dysfunction, dilation of left ventricle and right ventricle with systolic dysfunction in both, with here a calculated ejection fraction of 24 for the left ventricle and 18 for the right ventricle. We can see the mitral regurgitation secondary to the coaptation defect. And in sequences were taken for late gadolinium enhancements, in which we saw no enhancements, and as such, our images being negative for edema, fibrosis, or any infiltrative process. So next slide, please. Patient's family history was taken into account, and while our index patient, our proband, had this diagnosis of dilated cardiomyopathy at age 50, he referred no prior cardiac problems in his family. However, he referred that he had a younger brother who had passed away of a sudden cardiac death at age 39, and a younger sister who had had a stroke at age 31. And as such, these gave us a probable diagnosis of a familial dilated cardiomyopathy. So moving on. Our initial management during hospitalization included IV diuretics for treatment of the congestion and an up titration of heart failure guideline-directed medical therapy. At a first moment, this led to a symptomatic and biochemical improvement with a correction of the alterations in renal and hepatic values, confirming our theory that everything was secondary to the congestive state. There was a good evolution during the first week or so of hospitalization. However, at this point, we considered that the patient might be a candidate for discharge and follow-up at outpatient clinic. However, any attempt to wean the patient led to a new recurrence of congestion and lab values and congested clinical congestion. As such, pulmonary artery catheterization was performed, in which we can see elevated pressures on the right-sided cavities with normal pulmonary resistances, also an elevated pulmonary capillary pressure, and all of this consistent with a cardiogenic pattern. And at the same time, we can see a low cardiac output with a low cardiac index at 1.9 liters minute for index for body surface area, with a reduced mixed venous oxygen saturation taken from the Swan-Ganz catheter. So at this point, we have our patient with a diagnosis of a new onset dilated cardiomyopathy with a low cardiac output state and refractory to or dependent on intravenous diuretics.
Thank you, Dr. Mocorrea. So, Dr. Pan, would you like to make some comments?
I absolutely would. Thank you for that wonderful case presentation. That is a great case. I would first of all like to congratulate our colleagues in Argentina for the great care they're providing to this patient, because that's everything I think we would also do in our center to evaluate someone with this, presenting first with this type of cardiomyopathy. I would also absolutely 100% applaud the people who took care of this patient for getting a pedigree and a family history. As I think many of us are aware, it is an actual class 1 recommendation by the ACC, AHA, and HFSA guidelines to get a 3-generation pedigree for anyone presenting with a new onset cardiomyopathy. It is a recommendation that I think is poorly complied with in overall, simply because there's so many other things that we're trying to do for these patients. But it is, in my opinion, a very important part of the evaluation for patients like this, not just for themselves, but for their families as well. I think this case is very interesting because he's a younger person, at least in my world, as a heart failure cardiologist, is a younger person who's presenting saying they only had 3 months of symptoms, if I'm reading the discussion right. And this is something that I always say to our trainees, is especially when it comes to younger patients presenting for the first time with heart failure, maybe not to trust their history as much as you might think. or might want to, because, often, especially when you see an echo and MRI like that, I think we can all agree that this has probably been going on for much, much longer than 3 months to get that kind of LV dilatation and that kind of appearance overall on MRI. And so I think a lot of times when we're seeing patients with this kind of disease, a lot of them are oftentimes shocked for us to tell them that maybe this is something that runs in their family, because people think, oh, I must have been born with a terrible heart. And of course, that's not necessarily the case. This is, of course, something that develops over time with other risk factors, hypertension, et cetera. It's just a confounding factor that increases the risk for development of cardiomyopathy, is the way I talk to these patients. I think that's one thing that's also interesting on the EKG here, is there is some evidence of conduction disease that you sort of related to. The widened QRS, subtly widened QRS. Also, if I might have been imagining it, but I do think there is some delay in the AV conduction. And we know those are also factors that can increase the concern for an underlying genetic or inherited cardiomyopathy, especially because there are certain cardiomyopathies, familial cardiomyopathies, such as Lamin AC genetic related cardiomyopathies, that do present with both arrhythmias and conduction deficits, especially that first degree AV block. First degree AV block has actually been used in clinical trials for patients to screen for Lamin cardiomyopathy in trials that were specifically looking for a treatment for Lamin cardiomyopathy. So that's very intriguing to see. I could talk on and on, but I'll probably sort of wrap up here. Just saying that for patients like this with, I think we're very clear that the diagnosis here is at least an idiopathic non-ischemic cardiomyopathy, if not a probable familial cardiomyopathy. And work that I was fortunate to participate with in a multi-center study here in the United States with the DCM consortium, the Dilated Cardiomyopathy Consortium, a multi-center study where we went out, found patients just like this, and then went and found every single family member we could and did echoes, EKGs, and genetic testing in those people. And what we found was that if you actually went and took these patients and looked for their family members, if you actually looked for low EF in a family member, you would find it in 30% of families, meaning that at least 30% of these patients do have a familial cardiomyopathy. We just never really diagnosed it up front. And if you actually expand the definition of a familial cardiomyopathy to finding a family member with just LV enlargement, not necessarily a low EF, that number jumped to more than half. So actually that would imply that the most common cause of idiopathic non-ischemic dilated cardiomyopathies, just in this case, is actually familial disease.
Thank you, Stephen. Actually, with your last comments, you answered a question that I had about the recommendations following the diagnosis. Dr. Caras?
Yeah, I mean, I completely agree with Dr. Pan saying, I think the other thing to mention about patients with genetic cardiomyopathies is oftentimes a second hit brings them to the system. So patients may have a underlying even VUS or a pathogenic mutation, and they may be doing well for a period of time, but they may develop a viral syndrome. Something we're seeing more commonly is people are getting cancer therapy, and now receiving an anthracycline or other cardiotoxic medication brings out their underlying cardiomyopathy even more. And so think about always, if you see patients also that, you don't have a clear explanation, or maybe you don't completely understand why they're developing the cardiomyopathy, to always go back and check their genetic testing as well, and take the thorough family history. I think going forward with this patient, we all want to figure out now what is going to be the pathway for this patient. I think we clearly see that he has very advanced disease based on his 4-chamber enlargement. We know from his hemodynamics that he has low cardiac index, and as the resident was saying, they're having a lot of trouble weaning him off intravenous diuretics. So what is the best pathway forward now for this patient in terms of what therapies could we offer him, with the hope potentially of maybe some potential recovery, given that we're not seeing LGE based on the presentation? Is there some potential that he could improve, or is he going to need advanced therapies? Given his age, I think Dr. Pan and I would probably agree that sometime in his lifetime, he's probably going to progress to the need for potentially heart replacement therapy, like a left ventricular assist device or a heart transplant. But in the short term, potentially we could use things like inotropes in the hospital setting to then be able to get some more guideline-directed medical therapy on board. But also thinking if we're able to bridge him, can we use things like cardiomems to help guide his therapies in terms of assessing his volume status. We're meeting this patient a little bit too far along to think about a cardiopulmonary exercise test, but I just wanted to bring up for the general discussion, if you were to see this patient in the office, for instance, and Dr. Pan was mentioning many times, especially in young patients, it's hard to figure out what is somebody's true exercise capacity or exercise tolerance. Humans are extremely adaptable, and you can change your normal patterns of day-to-day life based on your symptoms. So we have the luxury in New York City of oftentimes asking patients, how did you get to the office today? And if they told you they took the train, then most likely they can at least climb a few flights of stairs, which is a good prognostic sign. But if they told you they took a car or a cab, or they stopped taking the subway and now they've had to transition to the bus, it may be a little clue that this patient is not able to do as much as they used to be able to do. So in those circumstances, in an outpatient setting, you can use a cardiopulmonary exercise test to better assess your patient's exercise capacity, and then use some of the more specific measurements on that test to help risk stratify that patient for them, and also to help guide what types of therapies you're going to be offering them.
Thank you. So let me ask you a question. So about a family member of this patient, not the ones that were shown there, but another family member that has develops breast cancer. And now you do an echo before you're going to give, let's say, trastuzumab or whatever, and the echo is normal. So how would you treat that patient differently from someone with the same breast cancer but without that family member?
So I think that one is, being sure that we have done potentially genetic testing on not just the patient who is about to get cancer therapy, but their family member as well. There's more data coming out now that, adding on these layered therapies may put patients at higher risk for developing cardiotoxicity. And they also may be patients that you're going to need to follow more closely on cancer therapy, or be more aggressive with potentially even treating them up front with some GDMT, knowing that they potentially have the risk to develop a cardiomyopathy. We always have to weigh the risks and benefits here, because some of these cancer therapies obviously are life-saving from the cancer perspective, but we have to weigh that with the risks of the cardiotoxicity. So I think it depends on the type of cancers, what is the course of treatment, what is some of the reversibility of some of the cardiotoxicity that we see, and then also take into account the patient's baseline cardiac function and family history.
Thank you. Steve, Dr. Karas mentioned inotropic therapy as which is an interesting concept. Inotropic therapy as a bridge to guideline-directed medical therapy. Can you comment on that?
Yeah, I think that is something that we always try to do. Whether we as a whole in a community have ever actually had much success with that, I think is debatable, although we all have our N of 1 or 2 where a patient was on Mirinone for like 2 years and weaned off successfully, and their EF is now like 40%, and it's a magical story. But I think as a whole, we in general, and this has been backed up by clinical trials in the past attempting to do the same thing, that as a whole, it tends to fail. And especially in a patient like this who appears to have, as Dr. Karas already mentioned, we're meeting him probably very, very late stage in this game. I think one of the most concerning concerning findings in this case vignette was, if you look at the labs, there's already evidence of end organ dysfunction. The creatinine is 1.45, the bilirubin's 2.3, there's elevation of LFTs. This is someone who honestly is in cardiogenic shock. So I think that in this setting, we would be using inotropic therapy to buy us time during sort of an evaluation period, whether to see whether there's any hope for recovery of LV function, or to furthermore then consider advanced therapies. The other thing that I might add, although again, I don't know if this is the most appropriate patient for this, but one other thing that I think us and many centers in the United States and out in the world, I should say, have attempted to do is to consider if there is severe MR, and I'm not sure if I saw echo images entirely to prove whether the MR was severe or not, but if there is at least moderate to severe MR, this might be a case where you could try a mitral clip in the right scenario to buy us time. But we know from the long-term outcomes in the COAP trial now that really what that does is it delays the need for heart replacement therapy. I don't think there's many cases where it avoids heart replacement therapy entirely.
Okay. And this is a question for, let me for Dr. Karas, but for both of you. Let's say that we meet this patient at an earlier stage in the progression of his heart failure. Does genetic testing help trying to predict a faster or slower clinical course?
Well, I think it depends on what you find on that genetic testing. So we do know for certain mutations that the clinical course may be determined by what you find. So for example, some of the ones that are predisposing patients to arrhythmias, you're going to be much more worried from that perspective. It may push you to put an ICD in much sooner or to also accelerate the evaluation for advanced therapies. Certain mutations, have very heterogeneous types of natural histories. Some patients may do very well for long periods of time, and other patients may accelerate more quickly. And then there's another subset of patients that we know from just more cardiomyopathy specific perspective that they're going to have more severe disease, and that should push us also to thinking about heart replacement therapy sooner rather than later.
Thank you. Stephen?
Yeah, I agree completely. It does entirely depend on what we find in the genetic testing. I always do try to tell patients that for the majority of genetic testing reports, it is not going to make a huge difference in what we do and how we approach their disease. And that I think that is true for like 95% of genetic testing. And really what it is, the importance of it right now is really to, one, answer the question as to why, because I think patients like to know why. But two, really more to discuss what to do about family members, whether family members are at risk. Because I think many patients, especially this age, have children, have brothers and sisters, have people that honestly we might be able to get ahead of the curve and help. And I think that is the dream, is to find people already at that stage A of cardiomyopathy before they develop any sort of structural disease and consider whether or not GDMT may help prevent the development. There's no evidence for that yet, but I think that is the grand hope of a trial one day if we are able to find genotype positive carriers. There are specific variants where, as Dr. Karas mentioned, are high risk, and those would be Lamin AC, RVM20, and a few smattering of others. FLNC is another one that I think we have a lot of concern about. But again, I think for the majority of genetic testing results, we do not have specific therapies or specific prognostication information at this point. The hope, of course, is that in the future, as we learn more about genetics and as we do more clinical trials, and there are clinical trials about to start of gene therapies specifically targeting specific mutations, specific genes in familial cardiomyopathies that may change that drastically in the next few years.
Thank you. The reason I brought up the EKG again is because we have a question on the chat line that says the low voltages in certain leads. Does that suggest any specific etiology?
It doesn't suggest any specific etiology to me per se, but it does suggest that this may be a more advanced cardiomyopathy. There's less muscle, or I should say less functional muscle, because of course this patient will have LVH if you calculate the entire muscle mass, just given the dilation. I think it just, to me, is a harbinger of badness more than anything else.
Dr. Karas?
No, I agree. I mean, I think the main point here is showing the severe abnormality of the ECG. And I think just the public service announcement, if people see anything like this in like a routine physical exam, or, you're coming for a different sick visit, that it really should be a sign that something is definitely wrong and that this needs to be investigated further. So we know that patients come to the emergency department for a variety of different ailments. Oftentimes they have an ECG, and the next step if you see something like this, is definitely to get an echocardiogram for that patient, even if it's unrelated to what their chief complaint was, to hopefully then capture these patients and then be able to offer them therapy.
Thank you. So that was an excellent discussion, really. Dr. Mocorrea, I'm going to go back to you to tell us what happened or what you guys did.
Okay, so the patient, following the clinical course, our patient was then diagnosed secondary to the pulmonary artery catheterization values with a low cardiac output syndrome. And he was started, well, I'm happy to hear that it was pretty much the same discussion we had and the same conclusions. He was started on IV inotropes. And as such, well, he was dependent on inotropes. The inotropes led to an improvement of the pulmonary artery catheterization values and the clinic and the lab values. But also any attempt to wean him off or to progress GDMT was met with a recurrent clinical congestion. Here in Argentina, we don't have long-term cardiac assist devices. We don't have LVADs. So our patient was evaluated and eventually enlisted for heart transplant. And the patient received a heart transplant 2 months after admission. The waiting time was primarily on account that our patient wasn't an emergency, that he wasn't on ventricular support, and that he had a rather large body surface area, so it was rather complicated to get a donor. Let's see the next images. The pathology, we didn't, I don't know if this is something that you would have considered. We didn't perform an endomyocardial biopsy at the time, considering that our patient was enlisted into transplant and that the explant would be available. We didn't consider there to be any benefit from an early biopsy. But well, the macroscopy on the explant was an endocardium with whitish fibrous areas extending from the base to the apex. And on microscopy, we could see an endocardial to subendocardial fibrosis, myositis, reparative fibrosis in the mid-myocardium with atrophic myocytes and interstitial fibrosis with reactive perivascular fibrosis and abundant nuclear pleomorphism. I'm not a pathologist, but our pathologist told us that these findings are common in dilated cardiomyopathy, but that they are not specific of any particular etiology, but that they are common findings that we can see in any etiology. So moving on. Well, regarding genetic testing, as was being discussed here, we know that dilated cardiomyopathy is this disease which has a locus heterogeneity, meaning that there are various subcellular structures, therefore genes that can be altered. So in this case, and regarding the approval of genetic testing, we know that there can oftentimes be a negative result on account of all the genes that need to be evaluated. So could you have next slide, please? We performed a Madrid score, which is a clinical risk score, which is to predict the likeliness of having a positive genetic test in a patient with dilated cardiomyopathy. And regarding the 3 points that our patient had, it gave us a result of a 67% probability of having a positive pathogenic variant. So genetic testing was requested in this patient. And the next slide, please. The genetic testing showed us that our patient had a heterozygous variant in a BAG3 gene with the following mutation. This is a gene that codes for a multifunctional co-chaperone protein, which is involved in muscle structure and protein quality control. This is a gene that has been previously described as a culprit in dilated cardiomyopathy. And the mutation that our patient had has also been previously described as pathogenic with previous reports in individuals with dilated cardiomyopathy. Next slide, please. So to conclude our case, our patient ended up receiving a hospital discharge 3 weeks post-transplant, which ended up being 3 months post-admission. Our patient, as I said before, he was from a more rural area, roughly 1,000 miles from our hospital. So he had a first follow-up closer to us, and then we were able to send him back home. And to this day, his latest evaluation was this last week. He has a 9-month follow-up without any organ rejection or complications secondary to the transplant or to the immunosuppression. Our patient is currently at a New York Heart Association functional class 1, and we are not us in our hospital, but there is an ongoing screening and evaluation of relatives being performed. And thank you very much.
Thank you. Dr. Karas, any new comments?
I just want to say thank you. This was a great case. I think it really illustrated a lot of different aspects of dilated cardiomyopathy, genetic cardiomyopathy, different things that we encounter, different therapies we need to consider. So I think you did a great job, and it sounds like the patient's doing well. So good ending to the story.
Stephen?
Yeah, exactly. I think that was a wonderful case, and it's not a rare case at all in many ways. I think that's the most important thing I'd emphasize about this. This is a common occurrence. We had a case just like this 4 years ago, bag 3. Same thing. We found the sister who was a PhD student who actually had an EF of 45% when we actually screened her. And then we found that her mother actually has an EF of 45%. And they're both on GDMT doing wonderful. And hopefully they will never need a transplant. So I think that's the most important thing I would say is like, this is a family now that needs a lot of attention, needs to be screened. Interestingly enough, I mentioned that DCM consortium study before. They actually did look at patients who went on to get LVAD or transplant within that cohort. And if you did genetic testing in just those patients, 1 out of 4 had a positive genetic test. So I think, in patients who end up getting transplanted for non-ischemic cardiomyopathy, that is a population we should really be focusing much of our effort in getting family screening and genetic testing done, because those are families that are going to be very high risk.
Thank you. We have just 1 minute. I want to ask a question to Dr. Mocorrea. This patient was listed for transplant and underwent transplant 2 months later. We talked about the target organ damage already in the laboratories. So how did he spend those 2 months? Meaning, did he have any form of mechanical circulatory support as he waited for transplant?
No, our patient he did not have a mechanical support, but he was with a continuous IV drip of dobutamine that was maintained during those 2 months.
Okay,
the whole hospitalization.
And then a question for either Dr. Karas or Dr. Pan. Dr. Mocorrea mentioned that the patient didn't have a biopsy. It sounded like, at this point it's kind of too late, doesn't matter. But again, if we had met this patient much earlier, would a biopsy have helped in predicting the clinical course?
I mean, I think it depends at what stage you're meeting this patient. I think by the time patients have 4-chamber enlargement and this type of deranged ECG, I don't think you're getting a lot of benefit. The things that you need to think about is when you see high troponin levels, you're seeing a lot of arrhythmia, heart block, always think about myocarditis. That's really where the biopsy is going to change what you're going to do clinically with that patient. And in particular, you really want to make sure you're not missing giant cell myocarditis, because without immunosuppression, the fatality is essentially 100%. So I think in my kind of algorithm, I'm thinking about acuity, conduction, this kind of the rapidity of the heart failure syndrome that's happening. To help determine whether biopsy is going to be helpful. But I welcome Stephen if you have any other thoughts on that.
As always, I agree completely with Dr. Karas. One thing I would say is the MRI here did not show any delayed enhancement, did not show any sign of infiltrative disorder or inflammatory disorder. So I think just based on that alone, I probably wouldn't have gone hunting with the biopsy. But I think if you didn't have that MRI, someone with fulminant disease like this, it would be absolutely reasonable to consider a biopsy, just to exclude the things that Dr. Karas just mentioned that have overwhelmingly terrible mortality. So.
Thank you. Well, it is 5:17, so we are going to finish on time. I want to thank everyone, particularly the trainees, because this is really for them, both the presenters, Dr. Javed and Dr. Mocorrea, but also Dr. Massin and Dr. Miselli for their candid expression of gratitude and telling us about the experience and really making us see why this is worthwhile doing. And I think that the relationship between our 2 chapters really epitomizes what the ACC was after in doing what they decided to do more than a decade ago, really. in terms of pairing a domestic chapter with an international chapter. I think that this helps us on both sides of the equator in trying to see what we would do with the same presentation. My conclusion is that actually there's not a lot of difference, and there may be difference in the availability of technology, but certainly no difference in the way that we think about the cases. As I think many of you know, I will be leaving New York in a couple of weeks. So this is my swan song. After doing this, 3 of these, I am sure that the governors have someone in mind that would take the baton. And I want to thank Carolina, Taylor, and the governors over the last, not just Dr. Feldman, but all the other governors that have preceded them for the work and the support they have given to this program. So thank you very much. I hope everybody enjoyed this, and I'm sure that we will do this again next year. Thank you.